Okay, now it's 3 minutes past the hour, so warm welcome. It is a great pleasure to welcome you on the first PHEMS meetup of this autumn season. My name is Pekka Kahri. I work in Helsinki University Hospital and I'm the project coordinator of PHEMS project. So today's topic is a roundtable discussion about pediatric health data space together with hospital partners that have not been in the closest inner circle in the PHEMS project execution, but are following it from the outskirts with an idea that they would be later on able to participate in the data collaboration that we're trying to reach with PHEMS. And our topic today, it includes 3 speakers and then a roundtable conversation after they have given short introductions, each of them. I will present our speakers in a short moment. The calendar for this autumn is here displayed. So we have all in all 4 meetups this autumn. So the next one, which is on October 21st, we will have a topic on synthetic data. Then in November, we will revisit one of our clinical use cases, namely the cardiac benchmarking in pediatric congenital heart disease patients, where Andrew Taylor will be describing the progress since his previous presentation that was in December last year. And then on the December meetup, we will have the view on how to involve patients, so young persons, advisory groups into data collaboration. So keep these on your calendar and welcome to join the future meetups. So our topic for today is a roundtable discussion about joining the pediatric health data space, which is our goal. We aim to establish a permanent collaborative arrangement on data between pediatric hospitals in Europe. And the objective of our project has been from the beginning to enable data collaboration between pediatric hospitals and address the pressing needs of pediatric populations and developing treatments and doing scientific research around pediatric patients of low patient numbers, meaning that cross-border collaboration is super important in pediatrics. But we need somehow a way to do it in a trusted and privacy preserving way. And this is how we have come up with the PHEMS project and the idea to establish a data space called the Pediatric Health Data Space to support this collaboration. Our work, or one part of our project work, has been to write a playbook. The playbook means high-level guidance on how we are setting up, how we are establishing, and how we sustain the solutions that we are developing in the PHEMS project, meaning that how can different types of organizations participate? How do we create value for data users? Are they clinical leaders, clinical researchers, scientists, or algorithm developers? And how do we manage the details of governance, management, and evolution of activities in a controlled way? We have developed technical requirements and common standards. We are developing a quite comprehensive legal package, which enables the participating organizations to understand their roles, their responsibilities. And we are also planning the business model, how resources and budgets that are required to run this activity are formed. The PHEMS project is now 2/3 complete. We have 1 year to go. Just to remind that we are 14 partners on a total. we received funding from the Horizon Europe program and the UKRI, totaling of 7 million euros. And as said, we have run for now 2 years and have 1 more year to go, including pediatric hospitals from all across Europe, coordinated by Helsinki University Hospital Pediatric Department. Other hospital partners being Great Ormond Street Hospital in London, Erasmus Sophia Children's Hospital in Rotterdam, the Netherlands, and San Joan de Déu Barcelona Children's Hospital, and accompanied by Mayors Children's Hospital in Florence and Children's Clinical University Hospital Latvia in Riga. And also then technical partners, companies, Veil AI, Genesis Biomed, Tietoevry, The Hive, and Aridia. So our speakers today come from our PHEMS participants and from the wider community of European Children's Hospitals Network, ECHO. So I'm happy to bring to the stage and introduce Elina, who is the Head of Research and Education in the Children's Clinical University Hospital in Latvia, Riga, and Beatrice Casarella, who is Project Manager at Mayors Children's Hospital in Florence, Italy, and Neil O'Hare, who is the Chief Information Officer in Children's Health Ireland in Dublin. So great to have you all three here, and we will start with short introductions from each of the speakers, and then we continue with a roundtable discussion. First, I would like to invite then Beatrice from Mayor to the floor is yours.
Good morning, everybody, and thank you very much. I'm Beatrice Casarella. I work at Mayor Children's Hospital IRCS, and today I will talk a bit about our situation, our hospital, and then what we are doing within PHEMS. Mayor Children's Hospital IRCS is a high specialized pediatric hospital and the National Reference Center for High Complex Pediatric Patients. Is really key hospital in our region, Tuscany, and is the head of the network of all the pediatric hospitals in the region. Our hospital is a university hospital, so we have a strong link with the University of Florence too, and in 2022 has been recognized by the Ministry of Health of Italy as a scientific institute for research, hospitalization, and healthcare for pediatrics. These are hospitals. We have 50 of these kind of hospitals in Italy, and these are hospitals who are a bit advantage in and have a strong link with the Ministry of Health and dedicated funds, and they are really focused on the research activities. So yes, from 2022 we have a big change in our infrastructure, in our mission, that takes research as a predominant role and importance within the hospital mission and activity. Within PHEMS, we are collaborating with the Children's University Hospital Latvia in the task of validating the governance framework and the playbook that has been developed and is being developing within the project. We are named as early adopters. So we have like to simulate a new entity that want to be part of the PHDS and the steps and that we have to take to be part of this ecosystem. And so we will iteratively validate and provide feedback to the developers of the PHEMS Playbook, representing, as I was saying, the experience of 2 new partner hospitals who wants to become full members of the ecosystem as data providers. If we can change the slide, please. Validation, during these activities, we found that the validation is a really important and strategic process, not only for within the scope of the project, but also helping our hospital and our situation to grow. Validation within the project ensured that the PHDS rules allow settable terms for new parties to join the ecosystem, and that participation is possible for hospitals that has lower at different level of technical and administrative maturity. We carried out our validation process. Until now, we have made one round of validation, and we are focused on three main themes: the text validation, the internal feasibility check within our hospitals, and then we will do an external feasibility check involving different stakeholders external to the project. And the feedback, then we'll share the feedback with the developers at the end of each round of validation, so that we ensure the most effective cooperation and contribution to reach the most effective and widely applicable final version of the playbook. As I was saying at the beginning, validation, we found that the validation is really a strategic instrument also for our hospital to grow. In fact, especially doing the internal feasibility check, we can raise awareness within our personnel and our CEOs and institutions, that awareness of the strengths and weaknesses of our own reality. And this can be a starting point for a future targeted implementation and to reach a higher maturity level and be able to be part of the PHDS. And so, doing this validation and seeing the collaboration with other hospitals, we can share experience and information, as also we are doing today, and build strong relationships that can help to reach our common goals. So our experience is really positive, and we are trying to set up all the steps to take to reach a higher level of maturity and be able to reach our goals.
Thank you very much, Beatrice. And we will continue the introductory rounds next up. So Elina Diminia from Children's Clinical University Hospital in Riga, Latvia. So Elina, please, you may take control, or I can change the slides if you
can keep control. Just change the slides.
I will keep control. Yeah. Okay, here you go.
Oh, thanks. I'm very happy to be part of this roundtable and discussion, and to share my view on this process. And I have around 3 years when I follow this development from our hospital's perspective. And always when all of us join some new teams, we try to introduce ourselves and our institutions. And as you see in the slide, then actually this is always quite similar. But I would like you to think about my hospital and try to imagine some similarities with hospitals in your country, or maybe even your hospital. Because hospital, it's not just the buildings or long-lasting traditions. Behind each hospital, there are stories. And let's imagine there's a country with 1.8 million inhabitants, or region in your country. And the population is decreasing rapidly during the last 4 years or 5 years in this country. And there is a hospital, only one pediatric hospital specialized providing healthcare for all specialized healthcare for children in this country. And children are approximately 19% of this population. This hospital, there are 250 beds, there are a lot of inpatient episodes, and there are a lot of outpatient episodes, and it's increasing this number of episodes. And actually, it's quite enough for this population, and it covers all pediatric population in Latvia. Therefore, there are broader responsibilities for this hospital. In this case, national responsibilities, in other cases, regional responsibilities. And since this year, we are a methodological management center ensuring high quality, unified pediatric healthcare nationwide. What does it mean? It means that we are involved in data analysis from other hospitals in the country. We are also providing training and different kind of guidance documents for our colleagues for pediatric care. And we don't have many opportunities nationally to ask for support. We are the only ones. In the same hospital, in our hospital, we have our in-house EMR system. It's built here together with our clinical staff and with our programmers. And we started to build the system more than 23 years ago. And this system there is a lot of investment done for interoperability. We can ensure interoperability with different kinds of medical technologies, as well as provide data to national e-health system and national registries, as well as national health service related healthcare costs, etc. That's already in place. And now we are in the next phase of transformation, because it's planned that our system will be used in other hospitals in our country as well. Even broader responsibility of this small team with 2,000 employees working in this hospital. And in this phase, we see that we have this new change, this new transformation is driven by changing needs and new stakeholders, the different kind of challenges and opportunities for small hospital, because still, despite of the fact that we are national level university hospital, we are small hospital, even more than in other than before, benchmarking is needed if we want to provide the best possible care for children, and we want to be active in adopting latest scientific achievements through clinical research. In this complex environment, we are actually not interesting for international large partners because we are still very small, and they have to go through the same processes as in other countries. Therefore, benchmarking and these shared resources and pediatric health data space related ideas is even more important for small centers than for large ones. And therefore, this role as early adopters and validation of Playbook is some kind of natural for our center, because it helps us quite a lot to develop ourselves, but we can give a quite direct feedback regarding possible improvements in the Playbook. Because it's quite clear from OECD reports that main barriers in building digital health systems is not so much technological, it's mainly institutional and organizational. And with this pediatric health data space and this Playbook we are validating, we are moving in that direction. And that was just one story of one hospital. But we are so diverse in Europe. And there was a publication by ECHO, it was benchmarking about healthcare resources in our hospital, ECHO hospitals. And in that small study, the difference between hospitals was from 150 beds to 580 beds. And there are standalone hospitals and large units in large university hospital networks. We can imagine that possibilities to use technical resources, expertise, and other kinds of support if you are part of larger hospital network is much broader than if you are standalone hospital with limited resources. There is also a difference between our hospitals because all of us share the same feelings that we have to use each patient data, each pediatric patient data to have better research for pediatric care. But actually, some of our hospitals are more research focused with a larger research staff and research groups in the hospital or in collaboration with universities. And some of our hospitals are more clinics oriented. Therefore, but each patient matters if we think about data for rare diseases. There are very different levels of digitalization and data competences, and also internal needs for data sharing and benchmarking and research. There are a lot of differences in technical, financial, legal, and administrative capacities, and of course, this umbrella, what we have, all of us, we have in our systems. There are different healthcare systems in our countries, and there are different national, international healthcare priorities. And why is it important when we think about validation? If we can identify through this process most important points where we can have to help and to support early adopters, that will help us to have better result of the first version of the Playbook. And Beatrice mentioned that we are doing this validation process, and we are aiming during this project to have a Playbook in place to support all possible partners and all early adopters. But actually, all finished projects or all finished activities actually is a new beginning. Because if we think about playbook, that it's the playbook and supporting documents will cover most important dimensions we need for pediatric health data space to start to work with this concept. But if we think about broader aim, why we came together as consortiums, actually overall aim is to improve pediatric research and innovations in pediatric care. Therefore, we have to develop governance and system which is continuously challenged, tested, and validated from different perspectives. And I believe that this process will give us possibility to transform data use across different stakeholders, because it's not a health, like in health definition, it's not a constant status. Actually, nowadays, to have sustainable changes, and we have to find ways how to make the systems where we can adapt them to different situations, and in our case, to different data use purposes as possible. In our project, we call it different use cases to use our data. Therefore, when we think about validation and playbook, then we have to focus on not so much on similarities. We identified similarities between our hospitals already in the first phase of this project. Now it's time to focus on differences, just to make this our idea sustainable for the future.
Brilliant. Thank you very much, Elina, for this telling the story and sharing your insights on how the process goes and how you feel that it is important and how it goes forward. We'll continue on a roundtable in a moment, but before that, giving the floor to our third speaker of the day, Neil O'Hare from Children's Health Ireland. So Neil, the floor is yours.
Thanks, Pekka. Do you want me to take control? Okay. Okay, so my name is Neil O'Hare. I'm Chief Information Officer for Children's Health Ireland, and the pictures you see in front of us are our goal, I suppose, if our prize, because we're building a new hospital in Dublin, and we're going to move from two very old hospitals into this very kind of interesting and digitally driven new hospital, and we hope to get in there kind of sometimes next year. Next slide. Oh, I'm sorry, I can share it. Sorry, apologies, Pekka. I think our aim really is that next year we'll actually open the new hospital after many, many years, and there's been a long saga in terms of the length of time it has taken to build this hospital in Dublin, and it's been kind of synonymous with delays. But actually, if you forget about that, it's actually an incredible building and an incredible amount of technology, and it'll really transform how we care for our patients compared to where they're currently in. And for example, one of them, Temple Street Hospital, dates back to the 1850s, and really it was an old house, so it's really not fit for purpose. So we're moving into this brand new building. It's located on the campus of another very large hospital, St. James's Hospital, an adult acute hospital. And as I've mentioned, we'll be moving from predominantly paper-based being almost fully digital, and that kind of brings fantastic opportunity, but I suppose a little bit scary as well. We certainly need to realize the vision of being what does it mean to be fully digital, and what are the benefits, and can we actually deliver on that for the taxpayer, for our patients, for our staff. So I think we're kind of all eagerly looking forward to it. I think it brings around expectations when we do this around the ability to be able to get access to data, the ability to share data, the ability to use it for operational clinical effectiveness, kind of what lots of people around the world have been doing for many years, but we kind of have struggled. And I think definitely to use that data to support high quality education, research and innovation. We are the National Pediatric Acute Facility. We do hold 39 specialties. We interact a lot with our colleagues in the UK and in broader Europe. And being involved in, I suppose, at the periphery of ECHO has been kind of very, very useful for us in terms of how we plan and how we kind of put in place the correct kind of technical and governance kind of aspects to allow us to get access to that data and use that data in a proper way. And I think we're definitely on that track of standing on the shoulders of giants, to really try and make a leap forward. I do have to make an apology. I have the most boring shirt compared to Pekka. So I think if you're becoming a full member of ECHO, I think you get it presented with really interesting shirts. So we'll leave that for a different day. Thanks, Pekka.
Brilliant. So thank you very much all for the introductions. And we then move to the sort of roundtable discussion part of this session. And I was thinking that we could try to touch and discuss on the sort of four building pillars or cornerstones of a successful pediatric health data space building process that we are trying to do together. First of those is of course data. We are talking a lot about data, and the foundation of data collaboration in a federated manner is that we somehow harmonize our data into a common data model. The data model that has been chosen for PHEMS project and as the foundation for pediatric health data space is the OMOP common data model. And I would like to start the roundtable with a question that how do you see and address the topic of data harmonization in your hospital, and what kind of path you see in using or transforming your data into the common data model, the OMOP CDM. Who would like to start?
Well, I might jump in because I probably spoke the least in terms of the introduction, so I'll use up some of my speaking time. I think for us, we're very much in the abstract at the moment. Yeah, we're looking to see what colleagues around Europe, and including some on this call, have done it. We've looked to really to learn the lessons of what not to do. Yeah. Which are as powerful as what to do. So it's lovely to go and see fantastic implementations, and where they really have got it right or got lots of it right. But equally finding out what not to do, I think, is equally important. I think all we can do at this stage is try and make sure that the infrastructure is correct. Try and make sure that we put in the right type of people to allow us to gain access to data. Try and make sure that we're standardizing as much as possible in terms of our data types, data, elements. Take best practice where we've been told it, and try and not to do something a bit left of center because we think we're special. Yeah, because I think the advice from colleagues around the world is you invariably have got it wrong, and you end up coming back to what the standard process is. So we've been really trying to do that. I think we're probably struggling at this stage without actually populating some of this and seeing what it's like, and then how would we actually do it, and how would we actually in practice start kind of federating out and sharing data. In this country, we're waiting for a piece of legislation to be passed called the Health Information Bill that will in a way enact the EHDS at a local level. And that's gone through some of the government, but it hasn't gone through the full government process, and that's been tortuously slow. So we're trying to really encourage the government to proceed ahead with that, as are our National Health Service. So I think there's bits of the jigsaw are there, and we're just trying to figure out what bits have we got, what are we missing, and then trying to fit them together. But we won't really build that picture until I'd say a year or two post go live of the hospital, and then figure out what we've forgotten about.
But that's an excellent insight, that also the learnings of what not to do, what is sort of where some of the early adopters or those who have been opening the path have gone hayway, so have not maybe done it well in the first try, and have been forced to revisit some of the fundamentals. So this is a great topic for anybody to consider. So not only to listen to the success stories, but also the the great failures. But Elina, would you like to make a comment on the data harmonization topic?
Actually, thanks, Neil. It's quite similar feelings because from one perspective, from our plans, it's quite clear. The first step we have to follow our national ways, how they look, what they expect from us. Because if we don't know their expectations from in national level, then it's quite easy for us to go in wrong direction. And actually, approximately 2 years ago, when I started to be part of this wonderful team, then I was like quite enthusiastic about OMOP, and I thought that I know what to do. And what we did, we tried to check internally the water, let's say like that. And what does are we ready for that? What can we do? And at the end, in that moment, I couldn't prioritize that in our institution in that moment 2 years ago, because there were so many other different needs in place, and I wasn't strong enough or my team was not strong enough to define value for that in that moment. But actually what we feel now through this process and have playbook validations, and actually we have more arguments and more insights of how to promote this idea among our administrative staff as well between our researchers with defined specific use cases. And from that perspective, we didn't start OMOP yet, but after 2-year period, we are much more ready to explain this need for our most important stakeholders, especially internally, because of course, locally, like we have to choose if we want to do some improvements in our systems. We have to choose between patient portal, for example, integration of new medical device, providing interoperability with national e-health system, for example, for prescriptions, etc., etc. It's always a choice. And I think that wise way how to go forward is put all our choices on table and argue for each of one and find the best way for us. But it's very important for our clinical staff and our IT and information system people to explain why we need that.
Yep,
and
thanks.
We have to be more mature to do that than my team was 2 years ago.
I think here also, I think standing on the shoulders of giants is one nice type of thinking, because the reason why our project chose the OMOP common data model was that it's something that a big community, namely the Odyssey community, has been developing and is developing with enormous enthusiasm and breadth. Not only the data model, but also then the analytical tools that are then available for all the high quality or value adding activities that we want to do. So here also, I think that it's the approach on standards and leaning and choosing those ones that have traction, that go forward, that develop and add value. I think this was one of our early discussions, and so far we have not been sorry for that choice. I think it's a good it has been a good horse to bet on, and hopefully it continues to be so. How about Beatrice? How do you see it at Mayor? You seem to have a different type of situation also in Italy compared to other countries with respect to your access to your data and control to your data. How do you see the role of a common data model and data harmonization and data access in Mayor or wider in Italian hospitals?
So I totally agree also with what Elina and Neil said, that our hospital in Italy are in a process from some years now, and we in our hospital also for different projects that we are in, we need really to implement and to also raise the consciousness and raise the awareness of the importance of this, that in the institution as Elena also was saying, the institution, our hospitals, the researchers understand the importance of it. The researchers and younger researchers also understand better the importance of it, and so the also the work is really on raise the awareness of the audience for and bring our explain what we are doing, the importance of it to the institutions. And so we have now within PHEMS we are also taking some advantage on this, on trying to understand and make understand and explain to others what is the importance. Our IT personnel also is working with external entities to, and they are trying, they have built some relationship to planning and harmonizing our hospital to common data model, because it's really an important issues. And we are in this process also. We have built some relationship, and we are starting to harmonize to this model.
Thank you very much, Beatrice. How about Elina? What are your thoughts? How do you lure the clinicians and the clinical researchers in your hospital to get excited about data collaboration and cross-border activities?
It's a challenge, I think, in all hospitals. But as I agree with Beatrice, that of course we have to attract young colleagues, young clinicians. But that's come together with another aspect, that in universities, and they are doing quite good now, in at least in our two universities for clinician medical studies, that they need some training, some basic knowledge about data-driven research, because it's a little bit like, from my experience, it's similar, but there are some differences, and we have to train analytical skills for them. That's one perspective. Then they come to our hospitals, they are more open to be part of these projects. But from other perspective, we can look to all our specialties in our hospital and try to figure out where the data makes sense. For example, intensive care doctors, they use data for many years in daily decision-making process. They understand the value of in the continuous measurements they have in the systems. Therefore, it's much easier to involve them than, for example, some other specialties, highly expertized surgeons, for example. For them, the data are not so essential in daily decision-making. Another perspective, where are data in hospital? Another perspective, to target geneticists and laboratory specialists and rare disease specialists. It's again where data plays significant role in daily decision-making. And then they understand data-driven decision-making also in research perspective. And third one, where data has a huge impact or workflow. And then emergency care is a place where we can focus our attention, because they have to triage patients, they have to make a lot of decisions in a very short time period. So for one thing is to find some new colleagues, with enthusiastic colleagues with data-driven mindset, but another is to look to specialties where data make changes mostly, like data has most important changes.
That's a great examples, and also reflects partly the use cases that we have chosen for PHEMS. There is intensive care unit is one of the disciplines where we are working now with algorithm development in PHEMS, and then also the rare diseases, congenital heart disease patients who are operated, and how the benchmarking of the care outcomes and process efficiency is done. So that's also very much into the field that you describe. I'm really keen on starting new use cases also within our context, because it's important that we get much more people, clinical people and research groups involved so that it does not remain a technical exercise. How do you, Neil, see in your context that you are now moving into a new hospital, huge transformation? How do you then get your people somehow also looking at these opportunities that are maybe a little bit beyond the sort of acute things that you are doing in your hospital, or do you do that at all? Do you dare to do that?
We do. I think it's not going to be as tricky as we think. So I think that if just listening to what Alina and Patrice said, I think there's different cohorts, you know, and you would tackle them very differently. I think we've got the kind of the clinical researchers, if I put them at, for want of a better word, at the top of the kind of the pile, you know, and the data set that we have, because we're not a big country, you know, and we are the national center, it's essential that actually we collaborate, and they do collaborate. That's what they do all day. You know, they've done it for many years. And others are involved in kind of registries and the collection of registries for rare diseases or normal diseases, if you want to call it that. And those registries are international. You know, they have to be by their virtue, by their nature. So I think that happens. You know, and I think if you go down a little bit and you find, you know, even kind of junior doctors who come in, they have to do research projects. It's often in the area of audit and things like that. Yep. And auditing ourselves is somewhat useful, but benchmarking ourselves against what others do becomes infinitely more useful and beneficial in terms of, you know, clinical effectiveness, operational effectiveness, whatever, you know. And I think, you know, again, the nursing cohorts do lots of that sort of stuff, and they're very good at it, you know, and exposure to international data sets to them would be really good. And then I think there's a cohort outside of that, you know. My interaction with my university, I know colleagues in the computer science department are dying to get their hands on a data set, you know, that they could effectively try and develop new algorithms. They're interested in the data set from the digital building as much as they are from the clinical data set, you know, and that's a totally different world. So I think we won't be short of people interested in doing this. I think it'll be controlling the processes, putting good governance in place, because you could let this run off, you know, and that could be very dangerous. So again, learning what others have done in this way to be able to control it, to be able to provide access, but in a very controlled way. Good audit trails, all of the good stuff that people know about, you know, but how do you practically do that, I think is the question. So I'm very positive. I'm really looking forward to it. You know, I think we'll get to this.
That's brilliant. Also, what we have learned during our project is that maybe one of the big strengths and also opportunities is where we repeatedly do the same kind of analysis. So refresh like dashboards with new data. This is where our PHEMS approach comes super strong, because once the heavy lifting is done of the agreeing on the indicators, harmonizing data and building the dashboard, then it's just, you know, automatically refreshed as often as you want and as often as the governance allows it to do. And I think that this is really a nice outlook for the future, that benchmarking can really become continuous activity without, in fact, too much effort anymore on the technical or the data stuff. It can just focus on collaborative and comparative analysis. Where are we different, and where does that difference come from? How can we learn from those who perform better, or who are the outliers, and where does it come from? Is it from reality, or is it the data that is somehow skewed? And this is highly useful for all future activities. Maybe one last round of discussion before we close for this afternoon. In order to get this off the ground, we have to convince your hospital leaders, your budget holders, your signatories that this makes sense. Do you see that there are major concerns, or what is the things that you have to have a very clear answer on when you present this to your hospital executives or your decision-making boards. What are the topics that you are sort of waiting to get, or where do you have to be prepared for? Also, where do we have to be prepared for to support you when making this presentation towards your hospital managers? I don't know, would you, Elina, like to start, elaborate that a bit from the Riga perspective?
I am not a technical person, therefore most scaring questions for me is, or most difficult questions is that, can you, Elina, specify technical requirements for us to do that? And that's, and even if I ask the same questions for our technical staff, this is something it's very important to have quite specific description of that. That's the one. The second one is to describe that actually it is very important not to lose control our data, not but our hospital collected data. And that's something we can use to promote this idea, because nobody wants to lose control. And the third, from legal perspective, then it's again not to increase burden on our legal departments, and as you said, that we are working for some package of standard procedures for that, and that would be very valuable for our staff, legal staff, to make sure that it's not extra burden for the legal staff. Because it will work only if it will be easier than doing it in an old-fashioned way.
Yeah, I agree. And there also maybe applies what was my comment previously, that once we've done the heavy lifting, the idea is that we do now quite a lot of work in defining the agreements and the governance model and the privacy assessments and the technical standards. And once this is done, so then it would be more straightforward to operate it, so it can become operational, that we don't have to think for project by project all these things through over again, but there is like a basis that we can work on. But Neil, how do you see in Children's Health Ireland, what would be your new boss asking you, and what would be their main concerns?
I think generally they would be incredibly positive towards it. I think if we're moving towards the aspiration of being an academic teaching hospital, then something like this, you know, is kind of core to that requirement. What would be the main issues? I think the governance around it. How do we share the data, and making sure that, you know, as Elina said, that's legally done right, it's kind of governed correctly, and that we're following kind of good practice and best practice, and that we can show evidence of that. That's useful for getting us into the PHEMS, but it's also useful for telling our paymasters that actually we're involved in Europe, we're involved in something really good at Europe, and we are following European best practice. So there's a win-win, I think, on both sides in that. I think the last thing I would say is deliverables. You know, there's nothing worse, I think, than paying whatever you're paying, you know, and after 3 years coming along and being asked, well, what exactly did you do for the last 3 years, you know? So I think that ability to show real deliverables becomes a self-sustaining practice, you know, and I think that would be really important.
Brilliant. Thanks a lot. That's also good for us to keep in mind, that we need to deliver, we have to showcase, and not just us as the project parties, but also those who then work with the pediatric health data space and do benchmarking or improvement of clinical activities or research. How about Beatrice? How do you see, when you go to work, talk to your hospitals, top executives, what would be their main concerns, and how would you approach or need support for those?
As was mentioned, Joanna, before, also because of our regional structure is really strict, and we have access to our data, but almost partially, because the data are collected mostly in the regional block. So we I think we really need some clarity of the technical infrastructure, technical requirements, as was saying Elena, that this could be really clear. And also, I think we need to, as we have to go beyond our own reality, we have to go on a higher level, our regional level, to to build some relationship and to them give us something that we are asking for many years. So we have to build, I think the key is to bring a strong plan and to give them really a plan of what we exactly need and what are the process to get to the objective, so that we can really explain and them can be really reassured that to open these strict structure. And then also the control of the data that was mentioning Elena. Yeah, I think these two,
Thank
because
you.
the technical infrastructure for us is I think the most access to the data is the most challenging part for us. Yes, so this could.
Brilliant. Maybe our project could support also the Italian partners and future partners in maybe raising some awareness and doing some our activities, maybe together with our sister projects in the funded by the European Commission that are also working with similar types of topics, but also then to support with some sort of targeted activities if there is a group of Italian hospitals, for example, who would make this see this feasible and could also make the contact and the engagement with the regional decision makers. So we're happy to do that. But now we are running out of time. So I see that one of our hosts, so Claudia, has her hand raised. So please, Claudia, go ahead.
We have a question in the chat, so if we have time, I know we're over time, but maybe we can answer that. It's Ruben Koch asks, are there any thoughts in FEMS how smaller hospitals that are not directly involved in research could benefit from the infrastructure? And he says, because their data contribution is also really important to not only have bigger hospitals and university hospitals data covered.
That is a great question, and I have to say that this is a work which is in progress. Our approach is that we go in like tiered or staged approach. Those who are now participating in FEMS, of course, we are the ones who are opening the track. Then we can expand it in the next stage into partners who are close, like eco hospitals. But after that, there is already in our thinking and in the basic concept is a way how can also other hospitals join and become part of this. And I think that it's a great comment that also smaller hospitals can contribute not only as providers of data, but then also as part of the collaborative network that we are building here. But thank you very much for the people who the presenters and roundtable participants, and of course all of you who are present here today. I'm just reminding that our autumn meetups continue in 1 month.